doesn't adjust to this moment. Type something on sideways. Oh, I see.
Do you know if it starts recording automatically?
I believe so. It will.
Oh, it is recording. Oh, no.
On the bottom left if it's on.
It's recording right now?
Yeah.
Here, so. And I'm finishing up waving to people.
Yeah, let's give it a few more minutes here.
Yeah.
Oh no, that's this.
Brooke says hi, guys.
Oh, hey, Brooke.
Hello.
Can't wait to see you.
Well, let's start with some current events as well. How about those Oilers?
Ooh.
They haven't lost a game in a week.
They haven't lost a game in a week.
Very true. Very true, guy. Okay, we got some more people joining in here. So one more minute, guys, and we'll get started. Rob's got his coffee ready to go.
Yeah.
Oh, we got Bub and 8 as well, saying hi.
Perfect.
Nice.
We got Yahia all the way from Toronto.
Hey, yeah.
Give him a shout out. We got a hey sunshine. Hello back. Lots of thumbs up. Rob just left. I don't know where he went. You hear this thing representing T-Dot? I assume that means Toronto.
Shout out to Dre. Is he back in Canada? Nobody knows.
I don't know.
He
makes too much money.
Hills, Alberta.
He makes too much money for us to know where he's at. All right.
All right, Zoom people, will get going in just a bit here.
1 minute, yeah.
Can you hear us?
We'll be pros at this in no time.
Okay, I'm just gonna make sure Zoom is hearing us.
All right. We've got a few people on Zoom too, yeah.
Oh, we're gonna allow these people to come in.
May as well do that.
May as well.
Or keep them in the waiting room. Oh, Brooke's on both platforms.
Oh, wow.
Wow.
Multi.
It's really wants to learn today. I guess we could get started. Yeah?
Yeah,
Shall we
let's
do
do it. Let's get
All right,
rolling
so,
here.
last week, on our story, I posted what kind of injuries people want us to go through. So this week is just laid out based on feedback. So we have the wrist this week, the neck and back, office work kind of things, how to keep up with, aches and pains throughout the day. Life's a bit different nowadays than it was, a few weeks ago. So we want to kind of give people activities to do at home and also a discussion in terms of we can talk about injuries, we can talk about whatever's bothering you guys. So even if you comment on, like direct message us on our Instagram page or even send us an email at info@pursuitofmotion.com, we can get to other topics next week, however long this thing is going to last. Don't know that yet, but we're going to keep doing it Monday to Friday and see how it goes and kind of see what people want to do. So if you have any suggestions for us, let us know ways we can improve things, if we can slow down or speed up certain topics. So today we have the wrist. A friend of mine asked us to comment on the wrist and kind of some common injuries to go through and some simple anatomy. We're not going to get too detailed like we learned in school. So we'll get into anatomy and then we'll also do some common injuries and then some exercises that you can do with minimal equipment. We'll have a bunch of exercises with no equipment and a few exercises that require like a soup can or something like that.
Yeah, exactly.
Which we'll show you guys. So yeah, without further ado, we can get into some anatomy, I guess, and kind of show you how the wrist looks like, the hand and wrist.
Perfect.
Yeah,
Absolutely.
Rob, take it away.
Awesome.
So I'll talk about the anatomy of the wrist a little bit. We'll keep it pretty simple, like Sunny said, but at the same time, we'll try to kind of allow for a foundation for the conditions and exercises that we'll talk about later on. So if we're talking about I get someone to put their hand a little bit closer to the camera and then I can, here, look at this. Here's a hand, there's a wrist. So So that's fantastic. So we'll kind of start from the elbow end and work our way down a little bit. So the major bones in the forearm, and you guys might be aware of these somewhat, but we have the radius on the top side from the way that Brandon's hand is positioned right here, and then we have the ulna, which is on the lower side again from where he's positioned. So these two bones, they kind of they run from the elbow down to the wrist, and it's the radius or that upper bone that forms kind of the larger portion of the wrist joint down here. So radius down to here, and then where the radius meets up with the next set of bones, well, we call that the radiocarpal joint. So it's between the radius and a group of bones that kind of run between the forearm and the hand called the carpal bones, just like that. So they're a nice mobile group. And then as we get further away from the carpal bones, we get into the hand, which is made up of the metacarpals, which are kind of the long. Can we get the anatomy app here too?
Yeah, for sure.
Okay, so that is this one right here.
Let's go to the screen.
Oh,
Go to
screen
share.
share.
And then
This one here.
there you go.
Okay, here we go again. So I think you guys can see my pointer here. So again, we talked about the radius, and this is the radius right here at the end of the forearm, down into the carpal bones, which is this group right here. You may have heard of carpal tunnel syndrome. So the carpal tunnel, as the name suggests, is a tunnel running through the carpals, and it's significant because it allows an entryway for the median nerve into the hand, and irritation or compression of that median nerve is that carpal tunnel syndrome, which we'll talk about more. And then getting down into the hand more, we have the metacarpal bones here. So if this guy had skin, this would sort of be the palm of the hand. And then we have the phalanges as we get down into the fingers here. Good. And then, oh, here we go. Muscle this guy up a little bit. So here, maybe we'll go back to Brandon's hand there for a second. If we could get the camera on him. Can I end the screen share here for a second?
Let's stop share.
Stop share. So from the anatomical position, which is more or less where Brandon's working from here, the different movements of the wrist are flexion, which is bringing the palm forwards, fantastic. Extension, which is bringing the palm backwards, good. Radial deviation, which is kind of a straight upward movement towards the radius, and ulnar deviation, which is straight down towards the floor or towards the ulna. And yeah, functionally, of course, often we're working in combined movements and rarely sort of in these straight anatomical planes. But those are kind of our pure movements there. Okay, and then getting screen share back here again.
Back over, I come this way.
Back to screen share. So if we zoom out to the forearm here a little bit, so this would be our elbow up here. Okay, I'll use the cursor for the people on Zoom. So from the elbow up here, we have the flexor group of muscles. Again, those are the ones that are going to generate that wrist flexion or moving towards the palm, and they come off of the medial corner of the elbow right here. And then from the other side, we have the extensor group, and this is going to be the group that's going to move kind of the hand backwards towards the back of the hand. And they're going to come off of the lateral elbow right here and run down the back of the forearm. So those are our important muscle groups there. And since muscles are always going to shorten as they contract, you can also imagine that the muscles running down the radial side of the forearm are going to be the ones to produce that radial deviation towards the thumb, and the muscles on the ulnar side are going to produce that ulnar deviation towards the little finger. If anyone has any questions about the anatomy, anything like that, just go ahead and post or comment. And yeah, otherwise, that's all I have to say about that for now.
All right, let me get this all set up.
All right, Sunny. All right, we'll switch back over to Sunny.
You guys might want to use some hand sanitizer after.
Sure.
After that. We got to follow the precautions. Oh, it's back to me.
Yeah.
All right, so we do have quite a few injuries that can occur with the wrist. As you can see briefly, that it's kind of like an anatomical, well, I don't want to say mess, but it's a very complicated area. The hand and the wrist can cause quite a few issues. So we'll go through some of the common ones. And then we'll kind of go from there through some exercises and kind of how to manage your injuries. So first one that I wanted to go through would be de Quervain's. It's got a funny name to it, but Our thumb actually has quite a bit of intricate anatomy. So we have a lot of muscles that do control the movement of our thumb. So if you think of it, there's a lot of working parts. So if there's a couple of tendons that do rub on each other quite a bit, so it's an overuse injury. So if you use your hand and thumb quite a bit, you can have a lot of friction in those muscles or in those tendons in the sheath, and then it can cause some inflammation. And what happens is people typically notice a little bit of pain in this area. Right here, it can go up the forearm a little bit. And for people on Instagram, right over here, if you can see that. So that's typically how it starts. You notice a little bit of burning, a little bit of aching, and then it can kind of get worse from there. So I see this a lot in the clinic with anybody that has a job involving even a computer station, people who work in the trades, things like that. Some of the weightlifters I see have that as well. If they're doing some front squats or cleans, you can notice some issues there. I had quite a fair share of wrist and hand issues when I started lifting a little bit more. So yeah, you notice a little bit of burning, it can increase. So you got to listen to your body about things. If it starts getting worse throughout the day, next day you notice more pain, you got to adjust some of your activity. So if you're at the gym working out and you're doing your thing, the pain gets a bit worse the next day, and it takes a couple days to settle down, you probably did too much. You probably got to scale things back, whether you're decreasing your volume or just taking a couple of days off. So, and if you're at the office, you got to adjust your workstation a bit. I know a lot of places have ergonomic evaluations and things like that. Yeah, so you kind of got to, sorry, my phone's ringing. So you kind of got to just adjust for activity. So yeah, at the office, just avoiding things that do aggravate the symptoms, taking regular breaks, things like that. So that's the best way to keep that injury simple. It gets a bit more complicated, but I see it a lot in the clinic. You guys probably do quite a bit as well. It's something that if you catch early, it's relatively easy to deal with. If you do catch the symptoms right away and come into physio or get some advice, you can kind of nip it in the bud before it gets too out of control. The other thing I wanted to talk about was wrist fracture, something a bit more traumatic. We went from an overuse to now a traumatic injury. So we call this injury a fouche injury. So falling on an outstretched hand, if you're just kind of falling down and the climate here is not so good. So if you slip and fall, you can fracture your distal radius, which would be this bone here. And this can lead to a number of issues. So you can have a cast on this if it's not a displaced fracture, and if it's displaced, so it's actually shifted a bit, then you're likely going to get some surgery. So we call that open reduction internal fixation or an ORIF surgery. Both situations are going to have the same kind of treatment. So the surgical route is going to take a little bit longer because you have to wait for things to heal a bit more. If it's for the casted route, once you're released or out of your cast, then the first thing is always pain-free range of motion. That's with any injury. I'm sure most people could agree with that, trying to get the full range of motion back. So that's a little bit about management about that injury. It's quite common. I see those quite a bit as well, especially in this climate. In BC, maybe not as much. So yeah, you have a mixture of overuse injuries. So like working at a desk for a long time, or traumatic, so falling down or some big event that happened to injure that area. So I can move on to carpal tunnel, or Brandon can move on to carpal tunnel just briefly and kind of explain what's going on there.
Yeah, absolutely. So carpal tunnel, it's due to a nerve irritation, and that specific nerve that we're talking about is known as the median nerve, which actually travels as the condition applies through the carpal tunnel. I'm going to just bring up the anatomy app real quick, just because it'll make more sense as I go through there. Oops. Go back to my Zoom people here. I can share it. All right, so carpal tunnel, as Rob was talking about a little bit earlier, if you guys picked up on it, actually brings us into this specific area right into here. As you guys can see, just with the anatomy of our anatomical person in this diagram, that all your flexors, so all the tendons that allow you to bring your hands like that and grip and go through there, actually have to travel through there, through this area known as a synovial sheath. Sometimes these areas can become inflamed, And you got to think of it as a little bit of, the area there, it's finite, meaning if it gets a little bit inflamed into the area, it can cause a little bit of irritation to the nerve there itself. Think about being on a busy subway or something, you're trying to like exit, just more restrictions that way there. The nerve within that area, the median nerve, similar results. So what can happen symptomatically, go back to our anatomic person here, since that nerve innervates the first 3 and a bit digits, so 1, 2, 3 and a bit, a lot of times people get numbness and tingling through those 3 digits there. One of the common signs that we usually see as well is this big muscle group here, known as your thenar eminence, known as your thumb muscles, tend to waste as well. So if you've been dealing with it for long periods of time, usually we'll see these muscles are quite decreased compared to the other muscles on the contralateral side or the opposite side of your body as well. So yeah, that's kind of carpal tunnel in a nutshell. Typically can happen with repetitive strain injuries. It's always that common desk worker, the person that has their hands in that position for a long period of time typing. However, we see it quite a bit clinically in anybody, to be honest with you. All right, perfect.
And then next, I just want to talk a little bit about tendinitises and tendinopathies that can affect the wrist. So we've jumped around a little bit from tendons with DeQuervins to bones with fractures to nerves with carpal tunnel syndrome. And now we're kind of making the jump back to tendons here. So again, like kind of considering like the forearm and the wrist, we have that flexor group coming off of the medial elbow and running along kind of the palmar surface of the forearm. Again, that's your flexor group. And then you have the extensor group running from the back, the lateral side of the elbow, down the back of the forearm and to the back of the hand. So tendinitises can occur either from the elbow, which would be something like your tennis elbow injury, or on the medial side, we call it a golfer's elbow injury. The other term for those would be like a medial or a lateral epicondylitis. A little bit of terminology. So itis always means inflammation. So an epicondylitis is always going to mean inflammation around the epicondyle, which is the term for these points here, lateral and medial epicondyles. Or alternatively, you can end up with tendinitis at the wrist joint as well, which can produce pain either on the palmar or the dorsal side of the hand. A little more terminology there. So again, itis, inflammation. So a tendinitis is always going to kind of indicate an inflammation of the tendon. But often when tendinitises are more chronic, so we see these all the time, they've been going on for weeks or months or longer. Often there aren't really true signs of inflammation at that point. So often we'll call those ones tendinosis rather than tendinitis. And again, where itis means inflammation, osis is more kind of an indicator of degenerative change. So like you might expect with an itis where things are inflamed, we're going to want to kind of rest. You may ice, let things settle down that way. When we get more into kind of that osis, kind of that more chronic tendinitis kind of a stage, that's often where we're going to be looking to sort of load those tendons again to kind of restore the health in the tendons. So that's an important distinction between itis and osis. And often you'll hear the term tendinopathy, which just means a pathology in the tendon. So tendinopathy can cover either the itises or the osises. Yeah, if that all makes sense. That's tendinitis. And again, that's often going to start off as an overuse injury. So again, that can be like your desk workers, people working in the trades, gripping, hammering, where you have kind of that vibration coming up through the wrist. Those can all be things as well that can set off a tendinitis. Or again, like if you have somebody who's fractured the wrist, often those structures will become a little bit less resilient while they're immobilized. So as you get back to activity after a fracture, you might end up with some wrist pain, some tendinitis owing to that as well.
Perfect. All right. Sorry, I'm running back and forth here, making sure the Instagram live questions are being answered, which is no questions currently, but we'll have time for that at the end. So that explains some of the injuries, common injuries or conditions with the wrist, a little bit with the elbow there, and quite a few things that have you guys experienced any of these before?
Tennis elbow. Yeah, from Wii tennis.
Yeah, from Wii tennis.
True story.
I had some DeQuervins from cross-country skiing, just gripping too heavy. Yeah.
And I had some carpal tunnel which I was freaking out about initially, because as a physio, we obviously have to be very good with our hands and feel things and things like that. So I was worried I might lose a career or something like that, but I treated it aggressively. So whatever I discussed with patients, I did myself, and it wasn't an issue. In a week or two, I was good. And now I still do my management techniques, which we'll kind of go through some of them as well. Some exercises, patients, I think, or clients think that, oh, it's easy, I don't need to do it. Kind of like if you're doing math at the beginning of the semester, it's so easy, you just don't even do it. And then it catches up to your physics or something like that. Same thing with exercise. You got to do some basics before you get into more advanced work and things like that. So our goal is to show you guys some exercises and kind of work it into a warm-up program. So if you're doing whatever it is, if you're working in the office, you're running, you're doing like playing volleyball or doing powerlifting, whatever it is, you got to have a management technique for your body. So stretching out joints and areas is very important, and I stress that with all my patients and clients, and I'm sure Brandon and Rob do as well. Is you just got to get a manageable program that helps, and then just stick to it, and that's the biggest thing. So we'll go through some of the basics, and then we can take some questions too if people had more specific questions to their injury, or if they wanted to see a little bit more, we can do that as well. So we'll start with the basics. I can go first, I guess, because I'll have to run back and forth between the technology here. So two basic exercises I do give out, depending on the condition, is a prayer stretch and a reverse prayer stretch. What I like to use it for is mobility. So if people are restricted in terms of range of motion, like their wrist is pretty stiff, I usually prescribe it to increase mobility and to stretch out certain muscles. So here I'm extending my wrist, right? So my hands are together. The biggest rule is to keep the full surface of your hands together and come down as far as you can. I don't have the best mobility, so that's about all I can do. Some people might be able to push it a little bit more, but the goal is to feel a bit of a stretch in this part of my arm. So I feel a bit of a burn. It's tolerable. It's not like it's a 10 out of 10 pain. And I hold that stretch for 30 seconds to a minute. Any stretch I typically give is 30 seconds to a minute. Lots of people try to cut it off short, and they try to warm up quick and then get into their activity. That's usually when injuries happen, is when you don't take the time to properly warm up. So holding this one, the prayer stretch for 30 seconds, and then the reverse, now I'm getting into wrist flexion and stretching my extensors. So I'm stretching these muscles on the arm and pushing up and holding for 30 seconds. So places to feel it would be on this side of the hand and kind of going up the forearm. So a nice strong pull, hold for 30 seconds. The entire surface of the hand and wrist are in contact. They're not kind of lifting off like that. You hold for 30 seconds and then kind of go from there. There's also these ones that we can show you a little bit later, but they each do the same thing. We just want to get mobility increased, right? These exercises are great too. This is great because you could do both at once. So that's one exercise. The other one is, so if you have the decurvance thing that we were talking about, you have pain in the thumb in this area here, you can actually grab your thumb and then point your hand down like that. So right now, for me even, I have a really significant stretch on this side of the forearm. We work as physios with our hands, so we tend to get stiff fingers and things like that and wrists. So if I do both at once, I'm grabbing my thumb, pulling down, and then holding for 30 seconds. And again, I have a good stretch. This is what I do. People think physios don't do the exercises they give, but this exercise I do every day. So some clients of mine will see me do this as I'm charting or just taking a short break. So those are a couple stretches to do. So you have the prayer, the reverse prayer, you have the decurvance stretch, all reps of 3 30-second holds is what I would say. All safe to do for anybody. You just work within your pain tolerance. So if the pain's getting worse as you stretch, that probably means you're pushing it too much. So take it easy. If you feel nothing, then bump it up a little bit. So you should notice slightly more mobility in the wrist and the forearm and less pain. That would be some things you can look out for those two exercises. And then I'll let one of you guys have some other
Sure,
exercises.
yeah. Maybe I'll jump in on the stretching just a little bit more. And I think Sunny made a good point too about pain. And yeah, just being careful with any exercises that you're getting into, especially if you're kind of unclear about about your diagnosis. Like for example, if you had like a muscle tear in the forearm, then you wouldn't want to be like stretching or strengthening aggressively. So yeah, just a word of caution on those ones. And yeah, then a little bit of the stretching here too. And Sunny had kind of mentioned these ones. But since I was talking about tendonitis earlier, I'm gonna kind of jump on them again here a little bit. So those forearm muscles that we talked about earlier, so the extensors coming up here and the flexors coming on the front side of the forearm here, they cross the elbow as they come up. So, and you can kind of practice or try this at home if you'd like to, just to kind of see the difference. But with a straight elbow, the muscles are going to be a little bit more on stretch across this joint. So you'll have a better chance of stretching the extensors, for example, with a straight elbow going into wrist flexion versus with a bent elbow going into wrist flexion. So, I mean, you can kind of see my wrist there too, a little bit more mobile when the elbow is flexed. And then the same, of course, is true for the flexors on the front of the forearm. So again, to get a little bit more of a muscle stretch, you might stretch with a straight elbow. And for more of a, like a stretch through the joint, you might choose to stretch with a bent elbow. Yeah, that's those ones.
Awesome. So as Rob kind of talked about, these are just, again, keeping it general, just a few things that you guys can think about doing over the next little bit. So I'm going to show one weighted one. Typically, we try to load tendons safely, but we also want to get them active too, right? If we protect the area too much, a lot of those muscles are going to start to waste, and you're going to have further problems down the road as well. Now, a simple one is if you have a free weight at home, or if you don't, a water bottle works good. A can of old soup you're not going to eat during the quarantine here. Those work quite well. So what you can do is a few different weighted ones with the weights. So one of the common ones is taking the wrist and working what we call eccentric motions, especially for these muscles on the top here. So if you think about it, it's basically kind of helping the wrist as it goes up, and you're kind of just focusing on the eccentric, or some people call it negative motions too. I've heard that as well, where you're kind of slowly going down, working between like that, 3 to 8 seconds from that end. And again, just kind of going quicker up or a little bit of assisted motion and kind of going slower down as well, okay? A few other ones you can do with your soup can is also working through some, again, as Rob talked about, some radial and ulnar deviations. Again, those are functional movements, right? If you think about grabbing something out of the cupboard, picking up a child, what it is, those are functional strengthening ones. Typically dosage, I always think about your first set as kind of your, to see where you're at. So for example, anywhere between 8 to 15 repetitions, trying to work through it through a few sets. At the end, you should feel like it's getting a little bit of a workout, but should definitely not cause pain as you're going through the weighted exercise. Perfect. All right, Sonny, let's get back.
I'll slide back, sorry.
Perfect.
I'm getting a lower extremity workout with pushing off.
Hamstrings, quads.
Quads right now. I definitely need it. So that was great, guys, and thanks for going through those. I think that covers some of the main exercises that are safe to do. Like with these presentations or tele videos, what we want to do is give people general tools to use. We can't do crazy complex exercises because someone might actually have a bad injury, and we don't want to make things worse. So I think the key take homes is stay active in any way and listen to your body. So a lot of people, we want to teach them about body awareness. So if they notice some issues, it's good to just take care of those things, right? Reach out to us or your physiotherapist that you have from the past. Just reach out to somebody and get some help for it, because it's usually not too bad to take care of. Even if you fracture your wrist, yes, it's a traumatic injury and it hurts quite a bit, but a lot of those get quite a bit better. Usually the overuse injuries go for too long. Like I'll get a patient come in and say, how long has your thumb been hurting? And he's like, 40 years. And then you have other things that may have happened in that time, like arthritis and things like that. So you don't want things to get more serious. So a lot of the times things get better on their own, but sometimes they can linger on. So it's all about consistency and listening to your body, I think, would be the most important things. Is there anything else you guys wanted to chat about at all, or?
No, not from my end.
Okay, so we want to open up the floor to questions, so people can, on either platform, on Zoom or on Instagram, just type in any questions that you have. It could be specific to people that you see if you're a trainer or coach, or it could be specific to your own injuries. Whatever you guys like, we can open it up. I wish I could cue like music or something.
Yeah.
I guess I could, but it could be anything.
Yeah.
Can I ask you a question to get the ball rolling?
Oh, sure you can. Yes, of course, Rob.
So, like with the power lifters that you treat,
Yeah.
let's say they have something like a wrist fracture or even like a tendonitis. Like,
Yeah.
what kind of criteria do you use for like return to sport?
That's actually a good question. So I treat a lot of powerlifters and Olympic lifters. That's the activity that I like quite a bit. Again, I always say this, but I'm not the best lifter, but I like doing the activity. So for criteria, return to sport, for instance, what I'll do is I'll see if it's impacting their sport currently. So if they're doing Olympic lifting and doing a clean, I'll use this example because I had carpal tunnel, which was due to my wrists weren't too mobile, so they were being stretched in cleans or catching cleans and doing front squats. I would say if it doesn't impact your activity directly, then you kind of keep going to the gym. But typically, the criteria would be relatively pain-free practice, and then you can go back into full sport. So I would take things down a bit. So if someone, for example, had pain doing these kind of activities, I'd start with a front squat and see if they could do that without making that quick motion with the bar, and then go from there. If that hurt quite a bit, then I'd have to take it a step back further. So I always try to go to a point that's very safe rather than going, let's just see you do the whole movement. I'll kind of start slow and then progress from there. So don't want people to get more injured. So typically the return to sport criteria would be relatively pain-free motion or strength. And that's sometimes tough because it's hard to have no pain at all. So I say, like, if it's a 2 to 3 out of 10 in pain scale, then continue the sport. If it gets worse while you do it, then you stop. So if it goes from a 3 to a 4 to a 5, then you discontinue the activity. If that makes sense.
That's great.
Yeah, that's good. Yeah, sorry, I tend to talk too much. So, and it's good to have that sport specific nature, right? If you're volleyball, same thing. You'd want to get to a point where you could perform all the drills and everything without pain. You can do that. Okay, now you practice. You could do that scrimmage. You could do that. Then you play a full game. So, yeah. Any questions on Instagram? Someone's got to ask one. Someone. I know there's some physio students and stuff like that. You probably have some questions.
It looks like we got. Oh no, never mind. So one question I get, Rob, and maybe I'll just get the ball rolling from your end too. Often with like a wrist fracture, sometimes people say, it's never going to be as good as it was. Is that something you think is true, or do you think that's a myth?
That's a good question.
Yeah.
And of course, it's one that we get all the time, right? And
yeah.
I think there's a tendency to think of fractures as being quite a bit more serious, right? If you compare that to, like, people might not take their tennis elbow as seriously.
Yeah.
But a fracture, I mean, you can see on the X-ray, there's kind of that mechanical deformity a lot of the times. Like, it's usually a pretty like dramatic mechanism of injury. So I think there is like that tendency, but I mean, with proper immobilization of the bone, and if X-rays show good healing, like the nice thing about a fracture is usually you can push the rehab like fairly aggressively, like within constraints, of course. But yeah, like from what I've seen, there may be like a little bit of residual like stiffness left in the wrist, and I think a lot of it depends on like rehab too. So I think like some people, they may have the tendency to kind of like pursue their rehab exercises until they get to a point where they're functional with their everyday activities. And then those exercises like are likely to taper off a little bit. So like for instance, a person might get like maybe 80% of their range back. And now since they're not noticing that wrist limitation anymore, they may kind of go by the wayside with the exercises for a while. But I think they have like a lot of like capacity to get back to close to 100%.
I got some questions, guys.
Cool.
Lots of questions.
Hope
you guys are ready. So, rapid fire. One person, I'll keep confidentiality, so I won't list who's asking questions. I guess everyone can see it anyways, but how often should I do these exercises in general? I guess what we just showed. So I can answer, one of you guys can answer.
Yeah, so I think as far as dosage, and again, we kind of talked about it, generally it's customizable, but I'd say a good thing to start off with, why not start between those 8 to 15 repetitions? If it's a stretch, like Sunny was talking about, 20 seconds to a minute, try and doing that maybe 2 to 3 sets, see how that feels. And then you can try it like once a day or twice a day type thing. But generally start to see how you feel with, 1 set, progress with 2 to 3. The biggest things, as we talked about, try not to get pain with it. And then the next day, if it's some of the weighted stuff, you probably shouldn't have too much discomfort other than delayed muscle onset soreness. But again, yeah, start lower and then kind of taper up as needed instead of the opposite where you start too high and you just fail and then you're unlikely to do the exercise anymore. Yeah.
Yeah, and then depending on your injury too, like you may end up tapering down at some point as well.
Yeah.
So like with my like tennis elbow, for example, and I still play tennis quite a bit. I was doing the exercises like a whole lot those first few months until the elbow was like basically asymptomatic. But during the tennis season now too, like I'll do that same exercise program like weekly or bi-weekly just to keep the issue from coming back to kind of maintain that tendon integrity. Mm-hmm. So it can kind of taper down at some point too.
And then we got quite a few questions. So Rob, while you're there, how long with proper exercise for elbow tendinopathy do you tell your patients it will take to recover?
That's a good question. I think that's that's maybe like an area that we don't always like address enough as physiotherapists. I think like the education like component is so important because it does take time with whether it's a tendinitis or tendinopathy, again, like the more acute or the more chronic types. But I think lots of studies will kind of have follow-ups that are like at least 3 months or 12 weeks and even going beyond that. So I try to tell people like do the exercises and like we hope that it's going to get better really quickly. But if after a week or two, like your pain levels are similar to where they're at now, like don't be discouraged and don't stop exercising because very often it can take months sometimes until symptoms get really to that minimal point.
And I guess like with that is it depends on how fast you're progressing with treatment. So if you're progressing relatively quickly within the first couple of weeks, then you can actually gauge that a little bit better in terms of a more of a long-term treatment plan versus someone who might not tolerate it so well and they take a bit more time. So
and Sunny mentioned sometimes too that people will come in and they've had injuries for like months or years. And you can just kind of imagine that the tissue health is going to be a little bit maybe lower in those people, so they may take a little bit longer to recover. And then it can also depend on things, even like smoking, which can kind of impact your recovery trajectory, and occupation as well. Like if you're in the trades, for example, and you have to be using a hammer every day, you're going to take longer to recover because you're kind of introducing that load all the time too.
Yeah, that's a good answer. Hopefully that answered that question.
Mm-hmm. I think it did. So we have T. Dot asking, how do you treat numbness in my fingers from carpal tunnel syndrome? So maybe I'll flip. Oh, there we go.
Oh, nice.
I don't like seeing myself that close, but for carpal tunnel syndrome, that's a good question. I mean, I've had it, so I can kind of speak on my experience, and then also some patients that have had it. So with that, I'd assess, how bad are the symptoms? Like, are you noticing it all day? I know you commented you had it on your index finger and your middle finger. That's kind of going to be, you got to even start a journal and say, hey, which activities cause the pain or cause the symptoms? So determine what the symptoms are, whether it's numbness or pain, and that's going to be your gauge. So you want to know what activities cause the issues and then kind of avoid them and see, okay, now I feel better. Whether you're laying on your side or you're typing on a computer, if you change the orientation of what you do and there's improvement, then okay, that's the activity that has affected your condition. So my thing with patients, and this aspect is a bit more difficult because we're not right there, we're not looking at your hands and seeing them, is to look at your activities and what is exacerbating or making the condition worse, and then kind of go from there. So like I said, the prayer stretch or the extension stretch is good. Even doing some gentle massage on your carpal tunnel area is not a bad idea, and just try these exercises, see what helps, and continue doing that. That's probably the simplest way I can answer that one without having a look at your hand. Hopefully that answers that question, and I'll make sure I don't get too close to the camera and put it on you guys. I'll put it on two better looking people. Okay, that's a couple more good questions actually. They're all great questions, by the way. So
We have, oh, Sun City Physio just joined. Hey, guys.
Oh, no way.
Yeah, look, oh, yeah, Rob's
No.
got some experience with them.
He's on the hot seat.
we'll just,
Don't take any of their
we'll
questions.
we'll just block them out, Rob's. Okay, so we have one person asking, do you believe that shockwave therapy works? I've been having this treatment for 5 months on my wrist and forearm, and I don't see a difference. Difficult one to answer, but we can all think of an answer, I think.
Yeah, why don't we all poke away at this, because I think we have similar thoughts.
Yeah.
Did you want to start? I think.
No, you go ahead.
Okay. So, yeah, so I think it's a complex answer because there's multi factors that could, influence what we call prognosis or treatment effect. In general, shockwave is more of, it's newer technology, and when I say newer, it's not new in the sense of being around as as a kind of a new thing, but just applied in the physical therapy and atmosphere. I think it's been a relatively interesting thing. I think shockwave therapy, having said that, means that we have relatively low quality studies. And when I say low quality, it means it just hasn't been examined very well in the research world. And sometimes these information that comes out with it show like relatively good results, but we just don't know what that means for the general population. And what makes things even more confusing is like, can we have that generalized finding be specific for a specific body site as well? So I would say from the research end, it's a bit hazy still, meaning that we need to kind of get a little more information of why we should kind of use it. And I know from like just physical therapy world in general, sometimes we try and focus too much on validating things that we can do instead of things that we know that generally will work for a specific injury. So that's kind of my thoughts is from the scientific world of shockwave therapy. What are your guys' thoughts?
Yeah, like you were saying, I think with shockwave therapy, like when I've used it before, I've always tried to think of it as being kind of like an adjunct to an effective exercise program as well. Like again, we know that exercises can work for. Sorry, was it like a tennis elbow? Was that the condition?
Let's see here. For the wrist and forearm.
Wrist and forearm.
That's all I got
okay.
off that question.
And really, like whatever the condition is, we know that exercises and activity modification can be helpful. So I would hope that, like in your specific case, if you've been receiving that treatment for that kind of a duration, that you've been like starting and working on like some kind of relevant exercise program as well. Yeah, like I don't have as much experience with shockwave, so I can't comment like too specifically on, especially any like more recent research.
Yeah.
But I know that like treatment protocols that I've followed before have been like relatively shorter in duration, like either one treatment per week or one treatment every 2 weeks. Again, like kind of from what I've seen, like 3, 4, maybe 5 treatments, that sort of thing. And then with like with kind of a rest and recovery period afterwards, of I think something like 8 to 12 weeks is what I've seen in the research when I've looked. So, and again, there could be new stuff out there that I haven't seen yet, but that was typically the protocol that I would be following was kind of those like weekly or bi-weekly treatments, 4 to 5, and then continue with an exercise program for kind of a month or 2 after that. And then I would always tell people that if they didn't get any better with the shockwave, then it's probably not the tool for them. If they did get better and they're 100%, fantastic. And if they got quite a bit better, but they have some residual symptoms, then I would consider doing like a second trial, like another handful of treatments. But again, that could be outdated now. That's kind of my working understanding of it.
Yeah. Oh, you, Sunny?
The easy answer would be, I agree with everything you guys say, and I do. And I think you guys touch on some good points. I'm kind of the mindset of continue what works. So like Rob said, it might be, after a prolonged period of time, it might not be the right tool for the injury. So I'm and we all believe in the same thing here at Pursuit of Motion. We think that a lot of these injuries can be self-managed. So
you have to have a self-management program at home in place to deal with some of the symptoms. So not saying that shockwave might not be right for you, because I mean, we don't know the diagnosis exactly, and we haven't assessed and treated you. So I think after that long of a time, you could just talk to whoever's administrating the treatment and be like, hey, you know what, this isn't working, can we try something else? I think having an open communication with your healthcare provider is probably the most important thing. And they won't take it personally. So when I have a patient and things might not be getting better how fast we want, then I kind of revisit the treatment plan and discuss with the patient what's not working or what else do you think we can do. So I get the opinion of the individuals I work with, and especially Brandon and Rob. I'll ask them if I have any issues. And yeah, so it's important to kind of go with what's working. So if it's been that long, then maybe a second trial that's more aggressive, or doing something else, doing a bit more activity and things like that. So hopefully that answered things without making too many people upset. We'll just flip it around again. Okay, back to Rob and Brandon. So we have one more question. With overuse injuries such as tennis elbow, what are some strategies that you give patients regarding activity modification? I can start with that, I guess, a little bit, give you guys a break. So activity modification, again, it's always about what activity is causing the issue. So if it's, like pronated curls or hammer curls, then to take those out if they make things worse. And any kind of gripping activity where you're kind of going like this or anything like that. So pull downs might be a bit sore. So the advice I usually give is to decrease. I never try to get rid of the actual exercise. So if someone likes going to the gym and likes certain activities, I say continue with it, but scale down. So do less reps or volume. So just take the weight down, take it in half and see how it feels. If taking the weight down and the reps help, then continue with that and then slowly add them back in as pain allows. So it's, for me, I just tell people, hey, if your pain's bad after a workout for 2 days straight and nothing's changing, then you probably did too much activity. So it's not so much modifying the actual activity, it's the parameters of it. So change the reps, change the weight, and then go from there and see if that makes a difference. And then, yeah, that's kind of what I would say about the quickest way to answer that question. Flip it back to you guys. There you go.
Yeah, I think Sunny did that's pretty much where I follow too, is just to scale back the specific activity. And Sunny kind of gave a good general like self-assessment of how you're doing and your pain levels kind of the next few days. The only thing I'd throw in the mix too generally is just like switching up like the activity. So maybe try different like cross training type thing. So like if, for example, I'll use my own. So cross-country skiing was killing me at the beginning of the season because I was gripping too much. So yeah, I just switched it up. Started running, didn't have to grip. And then my other few days of the week, I did cross-country skiing just to break it up. So I wasn't doing it consistently day after day after day. I was still active and kind of going through recovery, but just kind of switched up my activity per day.
Yeah, that's pretty good.
Yeah, I think you guys covered it beautifully.
I think we got some really good questions. All those are good questions, and I think the answers were superb as well.
We hope.
But I think we're a little bit biased. Any more questions? I'll leave this open for like another few seconds. If anyone has any questions, or if you want clarification for any of those questions, you can ask those. We have some people still joining, which is cool, but hopefully they got, hopefully 10 seconds they got Brandon's smile and it's good enough for them.
That's good, yeah.
We got some thank you, so I think that's probably a good time to wrap things up, unless there's any other comments that you guys want to make. That's going to be it for today. So we will put a link on our social media. So on Instagram and Facebook, we'll put a link of where to find this recorded video. And then tomorrow, we have the infamous hip flexor. So we're going to be going through the hip flexor and any other hip issues. So it doesn't have to be just that one topic.
Yeah.
And then we'll do the same style. So I think it worked out pretty well with Zoom. Zoom is a little bit more interactive. So for anybody on Instagram, you can check our bio and click on that link, and that can take you straight to Zoom. That way you could just see some of the screenshots a little bit better. Again, either way, you're going to be good using either platform. I know Instagram's pretty easy. Just click it and you're done.
Yep.
And we want feedback. So send us a direct message on Facebook or Instagram, or info@pursuitofmotion.com. If you had further questions about any injuries too, we want feedback, and we want to make this a really cool process and every day we want to be able to answer as many questions as we want and give it in the best format. So if you want us to do more activity or exercises, we can do that. Or less anatomy, more anatomy, whatever you guys like. So
Sounds good. Yeah.
Yeah, thanks for
Yeah,
watching.
thanks for
thanks
joining
guys.
us,
Thank
everybody.
you everybody. Thank you world.
Yeah. And we'll see you guys hopefully tomorrow.
Yeah, we'll see you guys later. Thanks.
Do you want to stop cloud recording?